Good evening, everyone. We are all here to see this presentation on digital workflow, basically more so for implant dentistry. So, digital workflow, I would say it has brought in dentistry, it has brought the agility and precision to implant placement, immediate provisionalization, and added to a satisfaction in the provisional phase. So the entire CAD CAM technology has provided predictability and comfort to deliver the definite restorations. I will brief outline today. I would like to speak on comparison of 2D planning and 3D planning, how it was earlier and today. Prosthetically driven virtual implant planning, digital implant workflow. So here I would like to briefly touch upon the scanning and all the scan bodies, how it is scanned, and the importance of face scans, and then slightly on the 3D printing, how we can utilize in-house 3D printer. So this transition from 2D to 3D has really revolutionized the field of dentistry, I would say, providing dental professionals with enhanced diagnostic capabilities and more precise treatment options. As we all know, the most commonly used 2D imaging would be the IOPAs and the panoramic X-rays. It allows us to visualize the individual teeth, surrounding bone, and as well as the oral cavity. The 3D dental imaging, which is also known as the CBCT, uh, is called as cone beam computed tomography. It's the more advanced imaging technology which is used in dentistry. This type of, I'm sure all of you are aware now, this type of imaging has provided a detailed and comprehensive view of teeth, bone, nerves, soft tissue, and surrounding structures in the oral and maxillofacial region. The Earlier, before CBCT, the third dimension was assessed based on the ridge mapping, like how we used to do on the place the implants using the 2D. Here I would like to show you, this is the ridge mapping which is being done here using the IOPAs and the OPG. We make the cast and make this measure the ridge mapping is the measurement of a procedure to ensure that diameter of an end osseous screw implant does not exceed the dimension of the available bone. So in this method, we are basically assessing the width of the bone and measure the soft tissue thickness at different points across the ridge and transfer it onto the sectioned cast in the edentulous area where the implant proposed site is there. Based on this assessment, the diameter of the implant used to be selected, and this is how the implant is planned there. So that this is the final drill of the implant which used to be assessed. And based on this, arbitrarily, it's not exact, the diameter would be fixed because still some amount of variation would be definitely be there as it is all based on measurements. Now, from moving on to the CBCT machines, like in late 2001, we got this accessibility, and initially it was very limited access. Nowadays, it's widespread. In most of the every cities has this facility, CBCT facility. So we used to make the CBCT machine use of CBCT machines before planning, like before we got the softwares and all much into digital workflow. We followed a small technology where we could do digitally by means of digital workflow. Basically, we got the CBCT done. We made a radiographic template like this. Then a stereolithographic model was uh, designed. I mean, this was again 3D printed. So on this, the drilling sequence was practiced on the model. By this way, you could assess the almost near accurate dimensions of length and width of the bone. There was also a color indicator for the nerves, which would emerge from the mental foramen. Further, the soft tissues were mimicked here. This is again arbitrary, using the light body elastomeric material. Of course, the measuring of the soft tissue thickness would be done on the CBCT sections only. We could see a faint line there and measure the soft tissue. This is an approximate assessment, I would say. The surgical guide template was prepared, and it was ready for use in the patient's mouth. Now, this is how the guide template is made, and it was used in the patient's mouth. I'm sorry, the picture is not very clear. I would say this is more of a drill guide rather than a surgical guide. We'll see what is the difference between that with drill guide and surgical. So this is how the transformation has happened from 2D to 3D. Today we will see in more detail how the 3D workflow has enhanced the predictability and outcome of the implant placements. So digital workflow in implant dentistry has increased rapidly in recent years due to the advances in the technologies such as softwares and the intraoral scanners. It has several advantages like precise planning. It said if you fail to plan, you are planning to fail. So planning is the most important aspect of the implant treatment. So that is very easier job done here with the use of software. So simplified surgical approach. So we'll come to know what are the needs and requirements during the surgical planning, whether bone grafting is required, how much is the bone, where is the concavities, osseous crater. All these can be assessed very well on the software. Then we have the possibility to fabricate the prosthesis prior to implant surgery. So the if we are planning to load it in the anterior region in the aesthetic zone, then we can keep the prosthesis ready and load the implant immediately. So this becomes more of a prosthetically driven implantology. We also call crown down implant positions, because we are going to place the tooth here and then the implant positions are fixed. Even in our analog method, when we did, uh, you could see that previous picture, we made the alginate impressions, the models were fabricated, and then we placed the teeth arrangement was done. We made something like an RPD, removable prosthesis, or a flipper, and that was utilized to make the radiographic assessments, and then that was used as the template. So basically, here more detailed approach is there. We'll just go and see how it works. Why we need prosthetically driven virtual implant planning? Often this question being asked by our fellow colleagues here, who are been doing freehand dental implant surgery from long time using conventional imaging techniques. And of course, nowadays CBCT. So most of the clinicians had successful outcomes till today. And when they did the implants with freehand, they don't have any issues with it. Definitely, I would say both have their own advantages and disadvantages with freehand and guided implant surgeries. However, right implant placement in terms of angulation and position is very important for the ideal prosthetic results. We may uh, come across cases where we feel that it's complex case for planning. In such cases, the guided surgery would be the best solution to overcome this complexity, especially the growing users of pterygoid and zygoma implants. It is better option to have a guided access. I would say guided access, not guided surgery. I mean to say we can have a simple pilot drill guide just to gain the access, because this is a critical area of the job. If you miss that first drill, then we may have to abandon the site sometimes. So in such a critical situation, the guided surge access gives us beneficial is more beneficial. And definitely for a beginner, virtual implant planning and single implant guide is definitely an easy way to kickstart the implant practice. The clinician is comfortable and familiar with the drilling instrumentation. Placing implants through a surgical guide not only reduces the time necessary to place the implants by 50%, but it also reduces the stress that the dentist experiences while placing the implant. However, sometimes we feel due to busy schedules and patient appointments, one may not, and also one may not be so much tech savvy to use the softwares and computers. Few may find it difficult to use this virtual planning softwares. In such situations, there are professional planning centers available where we can take the services from them and review the case planning done by them online through Zoom sessions like this and finalize the case planning. So basically, we'll visualize the complete case properly and how the planning is done. And this will help us to execute the case effectively. So here you can see the case with the freehand implant placement done for maxillary arch. We can see the implant angulations in different directions and also the improper implant positions. In such clinical scenarios, a fully virtual planned surgical guide may be recommended and would be more beneficial, I would say, to get the final prosthesis in place. Otherwise, we can see the positions of the implants now, as of now. The either the lab and everyone has to sit and struggle with the design. Of course, with the CAD CAM technology, it's much more easier now. This is the picture which I am showing from day back, earlier days. So, but now it is much more, process fabrication is also much more simpler and easier compared to earlier because of the digital technology. So moving on to the, I would like to start the demo here. I would move to the live software now. I'll share my screen. Just a minute. There is one more. So digital workflow for preoperative planning for guided implant surgery goes this way. The data acquisition is the first thing what we do. That is the CBCT. And then we have the intraoral scans for upper and lower arch. We need the both the scans and face photographs and face scans. Optional, of course. We need both of these for uh, doing a smile designing along with the implant placements. Once this data acquisition is done, we move on to the data importing and pre-processing. In this, we'll be having the CBCT data importing first, and then we'll be importing the intraoral scans of STL files of the upper jaw and the lower jaw into the planning softwares. And then we may do a jaw segmentation if there is a need for the jaw segmentation requirement is essential. Once the data importing and pre-processing done, then we go for the computer-aided designing. So in this, we do the virtual teeth setup, and then we do the virtual implant placement, and the scan body also can be placed, and further the designing of the surgical guide. Once the designing is done, we move on to the CAM, that is computer aided manufacturing. Here, either the designed aspect is either milled or it can be 3D printed. So two options are there in this. This is how we move on to the virtual planning on the software. So this is the opening page. I would say this is the software, planning software used for, is called as Blue Sky Bio. There are many softwares which are available for planning. So this is one of the software which I have been using and well acquainted with quite some time now. And this is the view opening window. So this section, what we are seeing is the cross sectional, and this is the axial section, and this is the 360-degree view. So we can rotate the bone around, and this is the 3D view, and this is the panoramic view. So these are the five windows what we see on the software. Let's see the software live now. So this is the basically the software, how it looks like. So there are different other digital solutions available in this software, but today we'll be dealing with the implant planning and the surgical guide designing. A simple case as a beginner, how to go ahead and do. I would like to show that case here. So there are, when you click on the implant selection, then we get one or two implant case or implant patient CT. So I'll go for implant patients, importing the patient CT scan. I'll go here, select the data. So this is how the view is seen. So I'm going to cut down what is unnecessary data. So what is only required, I'm going to keep that. So this is the opening window, what we saw there, same it is. So once that is opened, we can check here, this we can toggle this, and this is the axial view. This is how it moves. The lines here seen on the panoramic view, when we start shifting, it keeps jumping to the next sections. So you can see accordingly in the 360-degree view and the cross-sectional view, it keeps moving. Different sections are visible. So here is the panel here. Now we are going to draw the curve first. So we'll go to the tools. We'll draw the curve on the axial surface. This is how we are going to place the curve. So the missing tooth here is the 4-6 right quadrant, the fourth quadrant, and this is the missing tooth, and this is the 3D model. You can see the 3D model here. Okay, we can cut the unwanted data from here, go to the surfaces here, and then we can choose cut here. So once this is done, now next option would be first identifying the mental nerve. So we'll go and choose this mental nerve here. I hope all of you can see this. Detect nerve. So the artificial intelligence will detect the nerve. Where to click here on the mental foramen. So the software will recognize the nerve. So I'm just going to change the color of this, make it red. Yeah. So we can see here, this is the nerve tracing that is done. We can do the nerve tracing on left side as well. But however, our uh, case of interest is on the right side now. This is the tooth which we are looking at placing the implant. So I restrict to this now. Once the nerve detection is done, we can do the basic measurements. So on the panoramic view, I take these lines here where the proposed implant site is there. And then I'm going to take a measuring tool. So I'm just going to approximately measure the width and the height. So we have sufficient width and height now here for this case. So the 7.48 mm is the width and 12.43 mm is the length that is there. So with this length and width measurements, we can choose the implant and place the implant there. So before going to implantation, we'll just see how the bone segmentation, jaw segmentation can be done. Now with the latest version of the software, we have automatic jaw segmentation here. So we click on the segmentation here in the model master and untick this, use this mandible here and click on the start automatic segmentation. So the software makes the hard model of the mandible, which will be useful for placing the implant as well as checking the total bone, ensuring that the implant is within the bone. The software takes some time to load the model, mandible model. Yeah. Now, so this is created. I'll just click on the create surface. So this is the jaw segmentation done. We'll go to the surfaces. So we'll put off the CBCT data now. This is the jaw model, which is there now for this patient. Okay. So we can, in the surfaces panel, if you go and check, we will be having the model created, STL model. So this is the STL model that is created. And the tooth, each tooth in the socket are segmented again individually. They are separate in numbered here. So we can export them and print them as required for our applications. So this is the bone segmentation here done. Now next, we'll see the importing the STL model. STL model of the intraoral scans, that is the lower jaw. So basically, we need to superimpose the CBCT data, the hard tissue data, and the soft tissue data, which is the intraoral scan. And go to the file here, import STL model. So this is the data here. Now, it's getting loaded. The software is importing the model and it will align to the CBCT data. So it is going to ask us whether it is a maxillary model or a mandible, or I would say mandible, then say OK. Now, usually the software will align perfectly to the CBCT, but if it doesn't, the AI sometimes doesn't work. Now, this is how it is. It's not aligning properly. So I'm going to do with the points here. So we can align manually by placing the points. On the hard tissue. So usually 3 to 4 points would be better to do that. So I've done it, and now I'm going to say OK here. Click on OK. So here it is aligned now. You can see this line here. the pink color line that is adapting to the model here in the axial section we can see here. So it is properly aligning to the model. We can also check by putting off this original and try and see the segmented teeth, which are, I hope you can see there, it is perfectly aligned. So the advantage of the segmentation would be to determine whether they are perfect. Okay. So this is how the alignment is done. So once the model is imported into the software, next we're going to do the tooth placement on the model. So since I said it's a prosthetically driven implant, so this is the tooth. We can adjust the size as per the space available. Okay. So we have done the alignment of the tooth. So even if it is not accurate, it is fine, but we'll get an arbitrary position of the tooth. Based on this, we can evaluate the screw channel access hole emerging from the occlusal surface. So once this is done, we'll lock the tooth so that it will not move. Then we'll go for the implant placement. Now we have to move the advanced mode here. So this is add implant. We'll go to implant. So there are different libraries here available. So I'm going to pick up the dentium implant here now. Superline, 5 diameter, 10 length, mandible. So this is the real-time diameter and the length, what you can see here in the picture. So you select this. Going to adjust the crown here, the curve again. So we are placing the implant here. This is how it looks like. This is the buccal aspect. This is the lingual. We can rotate this lingulation. Okay, once the implant positioning is done, you can check 360-degree here. We'll rotate it as per the requirement. to angulate it properly to the adjacent tooth. So this is the most favorable position now. Once we confirm this, then we'll lock this implant. Now we can go and put the scan body here as well. Add scan body. We need to go and select the scan body, proper scan body for the implant from the dentium manufacturer and select it. So I'm going to align this here now. Align the scan body. So this is the scan body which is perfectly aligned now. We'll slightly change the implant position again. Yeah. So in this, you can see here, this is how it looks like, the implant position and the scan body. We'll put off this tooth now. Now what we can do is, along with the model and the scan body, export this data for preparation of the tooth crown. I just show the export. We need to go to the export data here. So prior to the placement, we can do all this planning. So we need to exclude all these nerves. We need to select the implant and the stone model. And this, we know, of course, we need to exclude this. Only the implant and the scan body and the model has to be saved together. So we need to uncheck this, export separated files to a folder, uncheck that, so that both the FTL which gets exported, the scan body is connected to the jaw model. With the help of this, we can design, go to the ExoCAD and design the crown. And just show that. So before that, now we'll export it and keep it. Now we are going to design the surgical guide. We'll go to the guide panel here. Now this is the implant that is fixed in position. Go to the guide panel. Then we click draw curve. Hold the shift button. Basically, the guide should support on the adjacent teeth properly. Can extend up till here. Second molar. Then I'll click Create Surgical Guide. So this is the sleeve diameter, what is being shown here. So this is how the guide is ready now. Guide is fabricated and with the scan body there in place. I'll just put off this. So basically there will be a cut window here to check the proper seating of the guide in the patient's mouth. Now this guide can be exported and 3D printed. So now next we move on to the designing aspect. We have exported the model with the scan body, and on the ExoCAD, we make a project sheet like this. So 4/6 is the crown that is to be designed. That is the anatomic crown with screw retained crown we are going to design. So this is the crown that is being designed here. This is the crown we can see here. This is the scan body which we got imported from the Blue Sky Bio. I have cut the model here because we are going to do the 3D printing of the model as well. So this is how it looks like. So our crown is basically it's ready before the implant surgery, and this can be kept printed ready for just provisional loading or progressive loading. We can reduce the contact, occlusal contact, and load the crown onto the implant. So this is basically the designing. So moving on to this digital impressions. So once we do that, we can also do the impression. Suppose if we don't plan it on the software, we can do the digital impressions. See, so the difference between the conventional and the digital impression, which are today more predictable dimensionally, the conventional impressions have dimensional changes and that builds distortion and inaccuracies into the final restoration. Digital impressions can reduce the possibility of dimensional change that is evident with all conventional impression materials. So voids, tears, and pull, tear of the drag of the impression, all that can be avoided with the digital scans. So the advantages, main advantages are there is no gagging, the material flow issue is not there, disinfection, and less costly and easy to store the impressions as they are soft format. To make the digital impression of an implant, we need something called as scan bodies. These are basically the impression copings for digital version. So the scan body is used to index the implant position and used to obtain a digital master model. So these scan bodies are made up of peak and TI base, various implant system provide them. It is system specific again. Whatever the implant system we are going to use, it's the same scan body has to be used. So they come up with the different shapes and designs and also the numbers. We can see the scanning here of an implant. The case what we did now, planning done for the 4-6. This is the opposing arch, upper arch scanning. We need not do the entire arch, full arch scanning since it's single tooth implant. We can just do a quadrant scan. This is the mucosal scan for the implant. So here we are going to capture the soft tissue data around the implant. This will help us to give the emergence profile for the crown. Once the soft tissue data is captured, then the scan body scan. So scan body scan is just capturing the scan body. We don't have to capture again all the data. We don't have to scan entire data, just the scan body. If it is visible enough, then the final is occlusion. This is the another case where posterior implants are there. So the scan body is placed and the scan occlusion is scanned. So this is the workflow here. So first we do the maxillary scan, then the scan body scan, mandibular antagonist scan, and the occlusal scan. So we get a complete workflow how to go ahead and finish the case. Moving on to the CBCT and the facial scan integration. Now this is the face scan which is done in the CBCT machine. Nowadays we get the face scanning in the CBCT machines itself. And this is how the face scanning is done. This data will be useful for recording the condylar guidance angle and the vertical dimension, which will be further used for virtual articulation in case of full mouth cases as well as complicated cases. So this is the face scan alignment. So we measure the distance, vertical dimension distance on the software. So once the all the data has been acquired from the patient, we have created a digital patient now here. We don't need a patient with us for further steps. We have all the data and we can start working on. Now here is the patient data, just a quick flow, how we designed this case. This is the existing dentition and the upper and lower jaw were scanned. And this is a case patient here with the existing teeth. So we have the photographs as well, the smile photograph and the retracted photograph, cheek retracted photograph. Now this is the existing arch. We virtually extract all the teeth here. This is how the teeth are being removed on the software. The lower jaw, this is how the existing teeth are. They are all grade 3, grade 2 mobile and chronic general periodontitis case. And here we make the edentulous arch here. And then we do on this ExoCAD software, we do a teeth setup like this for full arch cases. This is the existing and the proposed prosthetic plan. This is how it looks like. The lower arch comparison, pre-op and the proposed the lower prosthesis. This is the upper prosthesis and the smile design. So we show the patient how they look like, and this is exactly the same what we have designed there. And then now we go on to the blue sky bio and plan the implants as well, do the jaw segmentation, and we, yes, Dr. Ravina.
Please continue, sir. Nothing. They're just questions. I'm posting it off for you.
Okay, fine, thank you. So this is the prosthesis, which is planned prosthesis is imported into the software and aligned them properly onto the CBCT image. You can see the existing teeth, how they are. They are in different angulations, and they are moved from their original position. So we have done a perfect planning with the prosthetic phase. This is the implant position. Now we can see the green line here outline. This is the prosthetic line here, which is there, and the implant emerging from the excess hole emerging from the palatal aspect to the prosthesis. So everything is planned, and we come to know also what is the angulation of the multi-unit abutment which has to be used, whether it's 17 degrees, 25 degrees, or 30 degrees. So we come to know prior to the surgery, and we keep them ready on the table during at the time of the procedure. So this is another view where implants we can see here from the transparent bone. Now here the teeth are extracted, all the teeth are removed, and this is the space, soft tissue space that is being there. Moving on to the CAD designs, computer aided for prosthetic rehabilitation. We have these customized abutments which can be designed on the ExoCAD. Basically, these customized abutments give good emergence profile for the soft tissue aesthetics, and the margins are designed for easy and safe removal of excess cement here. We can see the how the finish line is, and this is the soft tissue profile that is being uh, developed in the patient's mouth. So this is an case where the custom designed abutment is milled in titanium. We have different options for implant restorations, like Emax restorations with TI base. TI base are one of the most uh, excellent abutments which are available for CAD CAM restorations, and they can be very easily used. And milled titanium bar is another one which is available for CAD designing, and milled peak bar. So all these options can be used for full arch restorations. Moving on to 3D printing, basically the 3D printers are available today, small desktop 3D printers, which can be used in office. And these can be used for various applications like crown and bridges, printing the splints, temporary crowns. We also have permanent resin nowadays, which is available, and we can print the permanent crowns. And different printers are available with a different price range, and they come up with their own resins as well. Different resins are available for different workflow. For example, surgical guides printing, we get different guide resin. This is how the surgical guide is printed using these 3D printers in office. So we design, export the guide, and print them. Now, this is the guide that we design now for that case 46, and this is how it is exported. It fits, and this can be printed using the surgical guides in-house. So this is basically the digital workflow for in implant dentistry. So in conclusion, I would like to say CT-based virtual 3D implant planning and placing implants through surgical guides will be a trending practice and becomes the routine digital workflow for implant dentistry. The technology will help the dentist to achieve more predictable outcomes. Not that we hadn't had the predictable outcomes earlier, but definitely it will become more easier, I would say, for the future generation as well as the beginners. Thank you.